Thank you, grazie e buongiorno. Prima vorrei ringraziare per aver accettato la nostra presentazione. Siamo molto contenti di essere qui, siamo qui per la terza volta a questo congresso SICSSO di altissimo livello. Allora, grazie. I shall present in English because it's easier for me. Dealing with bullous keratopathy after eventful cataract surgery is always problematic for the surgeon because you never know what it is behind the cloudy cornea. So you deal with a complex eye and you need to decide which technique is best for your patient. Of course, this patient needs endothelium change, meaning endothelial keratoplasty or penetrating keratoplasty, and most of the time a combined procedure like we had in this case series that I'm going to present here. So we took 41 complex eyes with history of eventual cataract surgery with pupillary or anterior chamber IOL, which developed in time bullous keratopathy and needed corneal transplant. All eyes needed combined surgery, so not only corneal transplant, but also removal of the existing IOL, another new PC IOL implanted, either on the capsule remnants or sutural sclera, as you will see, and some of the patients also needed pupilloplasty and or iris suture. 18 eyes underwent lamellar keratoplasty, ultra-thin DSAEK, 23 eyes of this group underwent PK. All surgeries have been done by the same surgeon, and of course the patient's complaints are very well known: low visual acuity, ocular pain, red eye, photophobia. And at slit lamp and pre-op examination we found, apart from the diffuse corneal edema with epithelial bullae, most of them, we also assume it is a posterior capsule break and vitreous in anterior chamber. It was difficult to be seen, but we assume it was that. Otherwise we could not explain the presence of a pupillary or of an anterior chamber IOL in the eye. And in some eyes we also found lens remnants on the iris, iris and sphincter damage, synechia, and in some eyes also secondary glaucoma. In both series we followed intraoperative difficulties in technique and intraoperative complications, and post-op we followed the disappearance of symptoms, restoring normal corneal transparency, eye anatomy, and post-op complication, and of course visual recovery with a visual acuity. In terms of surgical technique, there are of course important difference. First of all, on the DSAEK group we worked on closed eye environment, but because we needed to explant a PMMA IOL, we needed to make a larger incision, and we prefer the scleral tunnel incision, as you will see. Through that incision we explant the existing IOL and implant the new one, and then we close the incision, and for the second step of the surgery, the DSAEK itself, we follow the more or less standard technique with a 3.2 mm limbal incision. For the PK cases, of course, we start with the preparation of the graft, because we want to stay on open sky as less time as possible. And then all the surgery will be continued through this cornea opening. And at the end, of course, the graft is sutures. Let's see the first video. This is a case with bullous keratopathy with pupillary Fyodorov IOL. You can see exactly the steps that I just mentioned earlier. So scleral tunnel incision, one of the most difficult steps in this type of surgeries is the dealing with the existing IOL, the explantation itself. In this case we need to cut the anterior haptics of the Fyodorov lens, then we need to cut and to explant carefully the posterior haptics, which are in U-shaped haptics. You can see here one of them. There are three of them, and anterior vitrectomy is always a need in these cases. And in this case we prefer to, we choose Acreos IOL, suture with ProLens suture, 9-0 or 10-0 via ab interno technique. Although this IOL is foldable, we didn't need to fold it because anyway we had a larger incision, so we implanted on the sclera incision. We suture it, and then we close the scleral incision. Then we follow the standard technique for ultra-thin DSAEK with the lamella prepared in the OR with the help of the anterior chamber, artificial anterior chamber, and that's the end of the surgery, and that's my patient after 3 years post-operatively. And in the left part of the slide, there's another case of a traumatic cataract with an anterior chamber IOL. You saw some pictures and now you see the video. Also, we sometimes think that anterior chamber IOL is easier to be explanted. In this case, it was not that. Was not so, because as you see, with very gentle maneuvers, I noticed that the IOL was very well implanted in this angle. So I cut the haptics, and then very carefully, with very slow maneuvers, I need to withdraw also the haptics, trying to damage as less as possible the angle and the iris, which were anyway already damaged. As you see, in this case, I prepared from the beginning, as I told you, I don't want to stay too much in open sky, so I prepared from the beginning the conjunctival flap and the scleral flap, thinking that I will need a posterior chamber IOL to be sutured. But after having pulled the iris towards the periphery, I noticed that there are capsule remnants all are 360 degrees, so I was able to put a 3 pieces IOL on these capsule remnants, so I avoided the necessity to suture an IOL, which was very good for the future IOP of this patient. In terms of intraoperative complication, we didn't have any significant in both cases. Some bleeding in some cases from the cases which had cornea neovessels. The most difficult parts were, as I just mentioned, the difficulties in explaining the haptics and the IOL itself. And in the PK case, you can sometimes have, in most of the cases, difficulties in working on such an extreme soft eye. In terms of disappearance of symptoms and restoring normal corneal transparency, in all cases we had beautiful results with no difference between the groups, and you can see here some of the cases. These are the group with ultra-thin DSAEK and PCIOL sutured sclera. In the upper line you see pre-op, and in the lower line post-op results. These are the ultra-thin DSAEK group with the PCIOL sutured sclera, so very nice anatomical results. And this is the group, some examples from the group with PK, and most of them needed pupilloplasty, and PCIOL, it's sutured at sclera. In the right up you see an iris claw. Here you can see an angle supported IOL, and here you can see a Fyodorov pupillary IOL, so different types of IOLs. Again, an angle supported here is an old-fashioned choice for the ones who remember this type of IOL, and this is a pupillary Fyodorov, and the results, beautiful anatomical results. In terms of complications, late epithelial recovery was not that frequent seen, but what we noticed, and we expected that, we had 18 eyes in the PK groups with high IOP post-op, and some of them needed, 6 of them needed surgery. The number with the high IOP in the DSAEK group was much less. No graft failure or rejection in this 12 months follow-up. IOL-related complications, we had 2. In both cases, there were PCIOL on capsule remnants, so not suture. One in the DSAEK group with a minimal dislocation that we just left like it was. And in the other eye, it was a PCIOL put on capsule remnants. It also had cortex remnants, which in time quite soon hydrated themselves and became whiter and occluded the pupil and pushed the IOL. So we needed to re-enter in the OR and aspirate the cortex, and the things look fine. CME, cystomacular edema, was in 5 eyes in PK group, but it went away with topical treatment, and graft dislocation, only 1 rebubble in the DSAEK group. In terms of functional recovery, the difference were mainly due to the post-op astigmatism and refraction, as a matter of fact. Of course, the age-related macular degeneration, optic nerve atrophy could not be presumed only, but could not be diagnosed before the surgery. But the difference, an important difference, can be seen related to the post-op refraction, which in PK cases went to astigmatism up to 10 diopters, and even spherical diopter surprise. And this has an explanation, of course. In conclusion, from surgical technique point of view, the triple procedure with ultra-thin DSAEK is more difficult than triple procedure with PK. The technical difficulties are due to the need to work on a closed eye with poor visualization and compared to direct view on an open sky technique with little room for maneuvers and to the manipulation itself of the thin graft lamella in the UTI DSAEK. Sometimes the most difficult steps were the ones related to the IOL, the removal step. On the other hand, working on a closed eye, the DSAEK triple procedure has much less risk for serious complications than a PK. Moreover, being done on a small incision with only few limited limbal sutures, the post-op induced astigmatism in UTI DSAEK group is significantly lower and can be improved much quicker after a suture removal, only 1 month, than in PK cases. Although it is surgical more challenging, I would recommend to do as much as possible ultra-thin DSAEK in those cases, although choosing one or another technique is related to the preoperative anatomy of the eye and needed to be adapted to each case. Thank you.